Hello, my name is Fatemah Torabi and I'm presenting a national level case control study for determining risk of major cardiovascular events in people with epilepsy on behalf of the team at the Swansea University. To start with the background on our study, epilepsy is a tendency to have recurrent seizures, which are episodes of abnormal brain activity. Seizures can cause altered awareness and loss of consciousness. Apart from seizures, people with epilepsy have many problems, including higher mortality rates. Most people with epilepsy receive treatments of anti-epileptic drugs, known as AEDs. There is a possibility, not proven yet, that AEDs are associated with a higher risk of adverse cardiovascular events. It is yet unknown whether these drugs have an effect on major cardiovascular outcomes. Therefore, we aim in this study to investigate whether people with epilepsy who are receiving AED drugs are at higher risk of major cardiovascular events, and secondly, whether the risk of relevant cardiovascular outcomes differ between those on different drug types, enzyme-inducing AEDs versus non-enzyme-inducing AEDs. Enzyme-inducing drugs typically refer to older type of drugs, and non-enzyme-inducing refer to the newer type of these drugs. Enzyme-inducing drugs have been shown to increase blood lipid levels, and therefore they could cause more cardiovascular events. In our study, we used data within the SAIL data bank, which contains anonymized, routinely collected electronic health record data from secondary and primary care in Wales. SAIL provides an anonymized linkage field which facilitates the linkage between multiple data sources. We identified our cases from Welsh longitudinal general practice, with demographic details being merged into the case cohort from WDSD, known as Welsh Demographic Service Dataset. We also use annual district death extract dataset for capturing all cardiovascular related deaths, and any hospitalization for major cardiovascular events are captured using patient episode datasets for Wales. For our case identifications, we use a previously validated algorithm to identify people with epilepsy based on their primary care record. The algorithm requires cases to have a diagnosis of epilepsy as well as 2 subsequent prescriptions of an AED within the 6-month window. A cohort of people with a diagnosis of epilepsy between 1st of January 2003 and 31st of December 2017 was identified. The study entry date was taken at the date of diagnosis of epilepsy. For this cohort, individuals were eligible to be included in our study if they were at least 18 years of age at the diagnosis of epilepsy, had at least 6 months of available general practice data prior to their epilepsy diagnosis date. And in terms of follow-up, we required all cases to have at least 180 days of follow-up data. As shown in the right-hand side graph, the primary outcome in our study was the occurrence of a major cardiovascular event, such as cardiac arrest, stroke, onset of heart failure, or cardiovascular death. For the 10,241 cases with epilepsy, control cohort was obtained from all eligible individuals in Wales without a diagnosis of epilepsy and matched on a 1:4 ratio based on age, gender, Welsh index of multiple deprivation, and year of entry into the study. To allow a sufficient number of possible matches on the year of entry into the study, controls were returned back into the matching pool after meeting matching criteria, allowing matching with replacement and randomization. Where 4 controls were randomly selected from all possible matches for each cases. Therefore, some individuals within the control cohort were matched to more than one cases. We then performed survival analysis to evaluate the difference in time to first major cardiovascular events in patients receiving enzyme-inducing and non-enzyme-inducing and control cohorts. Our results shows for 10,241 cases with a mean age of 49.6 years and 52.2% males, we observed 2,115 major cardiovascular events, which accounts for 3.4 events per 100 person years. For the control cohort, there was 4,457 major cardiovascular events, accounting for 1.7 events per 100 person years. As shown in the graph on the right-hand side, the risk of experiencing a major cardiovascular event was higher in cases compared to controls, with an adjusted hazard ratio of 1.52. 31% of cases received enzyme-inducing AEDs, and 68.9% received non-enzyme-inducing AEDs. There was no significant difference in cardiovascular events between those treated with non-enzyme-inducing and enzyme-inducing patients, with adjusted hazard ratio of 1.04 for the cohort. To conclude our study, we have shown that individuals with epilepsy prescribed anti-epileptic drugs are at an increased risk of major cardiovascular events. This is regardless of treatment type, from our comparison of enzyme-inducing and non-enzyme-inducing drugs when compared with the matched control population. Thank you very much for hearing my presentation. Please feel free to contact me via Twitter and my email address for any questions. I'm very grateful for the team who have contributed to this study and are named here. Thank you.